Okay, so in regards to the final, it would be a summarized assessment from the beginning to the end. So again, the general survey, introduce myself. I would, I'm at work. Introduce myself, find orientation to the patient, look at them, kind of see their hygiene, grooming, their dressing appropriate, if they're answering questions appropriately, see any emotional, physical, or psychiatric, spiritual distress. Um, then I would move over. At the same time, I'd be looking at their skin, kind of seeing if there's any lesions, any open wounds, anything like that. Kind of looking at their hair, the way they're dressed and appropriately or not. I would then inspect the head. I would palpate for symmetry, for any lesions, for any open wounds. I would also look for any infestation, any bald spotting, any debris. Looking at the face, cranial nerve 7, I would be assessing what have the patient do eyebrows up or down, close or open their eyes, puff up their cheeks, smile with teeth, to looking for symmetry. I would also be assessing cranial nerve 5, which is the trigeminal, which have the jawline side to side. I would feel for any snapping at the TMJ point. I would hear for any clicking. Then I would move over to eyes. If I have to, I would do the Snellen test at 20 feet, have the patient read the Snellen test letters. A 20/20 means that a patient can read at a 20 distance, can read the letters as of someone else that could read at 20 distance from the chart. I would be inspecting the eyes for any discharge, any swelling, any lesions around it. I would also be looking at the sclera, at the cornea, for any edema, any discharge, any nodules. I'd be accessing the extraocular motor movements, having the patient just look with their eyes, no nystagmus, hopefully no nystagmus. I would do Perla, pupils are equal, round, reactive to light, and accommodation. I would have the patient follow the nose, follow my finger up to their nose so we could see the pupils move, medial, and then the pupils will go ahead and accommodate and dilate and constrict. Or, there's also a pen light that we could do that with. Ears, I would inspect the ears externally. I would be looking for any asymmetry, for any discharge, any edema. Then I would go ahead and inspect the tympanic membrane. I would look for the cone of light, which is at 5 on the right side of the ear and 7 at the left side of the ear. Pearly grayish is what we're looking for, a little bit of pink in the canal. We would assess for auditory cranial, which is cranial nerve 8, for the whisper test, and I would stand behind the patient, arm's length behind the patient, kind of lateral to the side of where I want to go ahead and want them to hear, and I would whisper a few words or a sequence of words or a sequence of letters or words or numbers, and have them repeat it, but they would be holding, closing the other ear. Vice versa, I would do it to the other side. Weber and Rhine test would be as indicated. Moving to the nose, I would inspect the nose externally for any lacerations, any discharge, any lesions, deformities. I would palpate for stability, tenderness, or any masses that I could feel in this area. I would also do the maxillary sinuses, the frontal, assess for any tenderness, any pain. I would use a otoscope or a speculum or shine a light under the nose just to kind of see if there's anything. I would look for any for moisture, edema, any bleeding, any ulcers, or any polyps. Throat and oral, I would inspect first the lips externally, making sure they're pink, they're moist. There's no open any open wounds surrounding it. Then I would look into the oral cavity, the buccal, the gums, the teeth, making sure they're pink and moist. Looking for the tongue, that it's also like pink and red, moist, no thrush, no ulcers, no bleeding, no cavities, no missing teeth. I would then assess for the tongue movement, which is cranial nerve 12. Have them stick out their tongue, move it to side. I would go ahead and do a minor gag reflex, and that would be cranial nerve 9. In the neck, I would expect for tracheal deviation. For any thyroid enlargement, I will palpate the lymph nodes, which is preauricular, postauricular, occipital, tonsillar, submandibular, submental, anterior cervical chains one at a time, and then posterior cervical chains and supraclavicular chains. We want them at a pea-size, mobile lymph nodes feelings. So behind the patient, I would inspect the thyroid at rest and with swallow, and I would want to know symmetry. I want to palpate for the thyroid side for the symmetry. I would assess cervical range of motion, so we would do flexion, hyperextension, the extension, and then lateral movement of the neck, shoulder shrug. I would want to put some pressure on the shoulder shrug, and that would be cranial nerve 11. Upper extremities, I would assess from shoulder to fingertip. I would look for size, symmetry, and deformity of the upper extremity. Fingernails, want to look for color, for capillary refill, less than 3 seconds. Looking for any clubbing, any lesions. Want to look for any nodules or tenderness or inflammation around the joints. That could make me think of arthritis. Want to assess the grip strength and the finger abduction and resistance. The wrist as well, we want to do rotation, we want to do flexion, extension, supination, pronation. Anterior and posterior thorax, we want to just go ahead and inspect 2 to 1 diameter. We want to see for any for symmetry, for any curvature, any lordosis, scoliosis on the back. We also want to assess for like the respiratory effort, if they're breathing too fast, if it's shallow, their expansion. Then we want to percuss, and we want to do the lazy S pattern when we percuss. Same thing with auscultation, we want to do the lazy S pattern, and we want to make sure we include the right middle lobe. That's pretty much for anterior and posterior, the same. The abdomen, we want to inspect and assess for the skin, for any lesions, any wounds, any distension, any firmness, just kind of like looking at it. Then we want to auscultate. That's the first thing we want to do. We don't want to palpate the abdomen and cause any noise to the bowels. We want to make sure we're not touching first. Auscultate each quadrant. It could take about 5 minutes or so to hear bowel sounds. You want to hear them with the diaphragm of your stethoscope. You want to also auscultate for the aorta, renal, and iliac arteries. You could use that with the bell of the stethoscope. Then we will move over to percussing. You would percuss over the abdomen. You want to know where you could, where you should hear tympani, where you should hear dole. Typically, dole noises should be over an organ. Tympani is usually where we primarily would have air. So in our lung, we would hear about tympani, over dullness, over the liver. Then we want to do palpations. We want to do light palpations, which is just like fingertips of 2, 3, and 4, just light palpations. And then when you want to do deep palpations, you want to rest the hand that's touching the abdomen, and put all the pressure onto the one that's on top of the other hand, and you want to go ahead and palpate inward. We would perform Murphy's sign, McBurney's point. McBurney is for the appendix, to find appendicitis. Murphy's, I believe that's for the gallbladder. The arbitrator and SOA sign is also for the appendix, or appendicitis. Lower extremities, we would inspect and perform any flexion, extension, abduction. So pretty much, flexion, extension. You want to do abduction, adduction, even with the feet as well. We want to assess hip strength with putting pressure above one of the knees, and try for the patient to go ahead and lift their leg. And then in regards to the Romberg test, you want to have them close their eyes, stand feet together, hands at their side for about 20-30 seconds, and making sure they're not swaying or moving. Romberg test is the heel to toe test. Have the patient walking, making sure their gait is stable and they're able to do this without, moving to one side or the other or falling. Then we have the deep tendon reflexes, which would be, it could be the brachial, radial, the biceps, the triceps back here, triceps, the biceps, and then the brachial, radial right here. We would assess them on both sides, and then we would do patellar, which is right below the knee, and then the Achilles, which is like in the back of the foot, above the heel, you could say. I think that it's just a quick summary. I know I didn't do a really good job. Once again, I apologize. I didn't think that I had to redo these videos, pretty much, that were part of the midterm and final checkoffs. I didn't know I had to do them like in video. I understood it as, going and just doing that.